Sounds good.
Hi everyone, thank you for attending our virtual dental shadower session. We wanted to remind you that in order to get your hours, you will have to take a short quiz, and as long as you get 3 out of 5, you will earn your hours. The quiz link will be located in our link tree, which is in our Instagram bio. All right, let's get started. We are very fortunate to have Dr. Deleon for today's session. I am handing the mic over to you. Feel free to start whenever you want.
Awesome. Hi, everyone. My name is Dr. Deleon. So a little bit about me. I'm a general dentist. I graduated from LECOM School of Dental Medicine in 2020, and I'm back in the Bay Area right now at UCSF. It's in San Francisco, in a residency program, graduating in about 2 weeks. So AEGD stands for Advanced Educational General Dentistry. It's an optional 1 year program, just for extra experience before going out to the real world, I guess. And right after, maybe 2 months after, I'm starting my own practice. So kind of taking the expedited route here. So here's some study tips and advice on staying motivated. It's not really geared towards the DAT. This is kind of more in general, or once you get to dental school, this is how I survived it. Definitely make outlines, but always remember to look at the bigger picture instead of being so meticulous on the small details. Um, you just get too wrapped up in it sometimes. So just take a step back. What helped me out too was making sample questions for yourself for each section that you study. So when you can go back and quickly review, quiz yourself to retain what you learned. Definitely stay active and exercise so you're more alert when studying. I know we rely on coffee sometimes, but definitely get some fresh air and learn when to take breaks. You can only take so much information. Um, Sleep on it, or even have like a reward system for studying a certain amount of material. What also helped me out was making silly mnemonics. They're easier to remember, especially when you study with your friends and make up mnemonics together, and then you can quiz each other. What helped me too was asking upperclassmen for help. You know, just they just gone through what you did, so they have, hopefully they're able to help you out too. Something I did differently was I actually played some games while studying. It just kept me alert and awake, so that helped me out. Choosing specialties. So, after dental school, you can go get some more education, add on to your debt if you want to. There's many options like ortho, where you can specialize in braces, endo, do root canals. I originally wanted to do ortho, but there were many things that were holding me back. First of all, I was in a long distance relationship for 4 years, so ortho would mean committing 2 or 3 more years, and I wouldn't know where it would end up, so I just couldn't do that. And seeing that I wanted to start a family soon, that was just not in the picture anymore. Um, Another reason was cost. So when you go into a specialty program, some of them they offer a stipend, so they give you an allowance for the year, and then they make tuition. They don't charge tuition, but ortho they first of all you have to pay for tuition, so it's gonna add on to your debt, and then you don't get a stipend either for at least most programs. Um, Lastly, during dental school, I didn't get much exposure to um, any ortho procedures. So, I didn't want to commit to something I wasn't 100% sure about. So that's kind of what led me to the AEGD residency. So again, that's advanced educational in general dentistry. The things I liked about it was, no tuition. They gave me a stipend for the year. And an option that's great is I'm able to get my California license through finishing residency instead of taking a boards examination. So the boards, traditionally you have to bring in a patient who has specific cavities that you need to work on. on the day of the exam. But being graduating during the beginning of the pandemic, it was a huge risk to try to get a patient in, or if you could even take the exam in person. So I was fortunate that I got into this residency program to get my license this way instead. It was only a year commitment, and even better was it's in San Francisco, and that's where I'm from. So I got to move back home. So I got to really, I feel like I hit the jackpot with this program, and I learned so much. So in dental school, you typically see 2 to 3 patients a day at most. You have a lot of time to, because you're new at it. You got to learn, and there's a lot of checking by the faculty and all of that. But now, like in residency, we increase to 6 to 8 a day. We'd probably be seeing more if it wasn't the pandemic, but with all the extra precautions, kind of slows us down a bit. So at UCSF, I'm seeing different cases like with operative, which is the basic drilling and filling, doing some crowns, dentures, some extractions and surgery. What happens is we have different days that we do different procedures. Like for example, on Tuesdays we do a lot of surgeries. So that's what I'll be doing, like full mouth extractions, where patients have really forgone their oral health, and most of the teeth or all of them have to be extracted. So I would extract them all and then have a denture ready to go, so they can come out with some teeth, right? We also do some implants, which is pretty unique for my program here. Usually, they don't let general dentists just place implants right away. Usually, the specialists would do that, but I got some exposure to placing implants here, so that's nice. The most common patient concerns I would get are like, I want my front teeth fixed, or my tooth hurts, right? Um, and then the toughest parts about proposing treatment plans, the toughest part for me is always talking about the cost. No one wants to hear like, oh, I need to pay $9,000 for treatment. And so the biggest thing that helped me out was building trust and building a relationship with that patient, because no one wants to spend that much money on something that they don't see the value. So I would, build a rapport with them first, and then maybe start with a couple smaller treatments, like their immediate needs that will fulfill like their chief complaint, what they came in for, and then everything else I would like add on once they understand what's going on, and once they trust me more too. Another thing is insurance. So with insurance, it's really tricky. Not every procedure is covered by the insurance. So you have to be really careful of like your treatment plan, and letting the patient know that some things will be out of pocket, um, and just knowing the nitty gritty details about that. So I guess I have a couple of dental cases to share. This first patient, her chief complaint when I met her, she said, I broke my front tooth on eating a chicken bone or chewing on a chicken bone, and I want an implant. So she has no significant medical history. So I presented this treatment plan for simple extraction, immediate implant with bone graft, and an S6 retainer. So I'll kind of break that down. So simple extraction is just basically a normal extraction that you just take out the tooth, right? Immediate implant. So usually with implants, you usually you do the extraction first, let the bone heal for, I'd say like 4 months, and then take a scan, like a 3D scan, CBCT scan, and then plan how are you going to place the implant. But sometimes if all the parameters are right, and like in this case, the bone around the tooth was good, and patient was compliant, Sometimes you're able to just take out the tooth and then put an implant right away, and then put a bone graft there to fill in the gaps between the patient bone and the implant. Last of all is an Essex retainer. So what that is basically, if you're familiar with Invisalign, like those clear trays, I would make a clear tray for the patient and put like a fake tooth in there. That way she can wear it just for looks. So let's just go through the photos for this. So this is the extraction here. So the biggest thing for immediate implants is you have to make sure that the extraction's atraumatic, meaning you don't do a lot of damage to the gum and the bone, um, and clean out the socket well. So here I use a scalpel to cut around the root. So fortunately, she had the root of her tooth still in there, and kind of act like as a space maintainer, and also so her bone doesn't um, resorb. Meaning, so with 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 teeth, they have a root, and then the purpose of the bone is to hold on to the root of the tooth for stability. But when you don't have a tooth anymore, there's no purpose for the bone, so the bone starts to shrink. So in this case, she still had the root, so her bone was still intact. So here I took it out atraumatically, and then I started with an implant system. So implant drills, there's different sizes. You start with like a skinny, and then gradually go wider to almost the size of your implant that you're eventually going to place in there. So I started with a skinny drill, and then placed this rod in there to take an X-ray. Sorry, I don't have a photo of that, but basically, the X-ray shows if you are in the proper angulation, and if not, you can easily correct it once you go to the wider implant drill and just make sure you go to the right direction. So in this case, I took my time, got the right angulation, and on the right side, you can see that the implant fixture is there, and the top of the implant is right at the level where the bone is. So this patient's already had implants before, so it was nothing new to her. Next, the the things around this is the implant screw cover. So after you put the implant in, you put a cover screw on there, you screw on the cap so nothing gets inside of there, and then pack some bone grafter on there, which is bovine, cow bone, and that's just to fill in the gap there. And then that will take about 4 months, 4 to 6 months for the bone and the implant to also integrate, which means for the implant to integrate with the bone. And then I sutured it up to close it up. One important thing is you don't want to put any pressure on this implant while it's setting in the bone. So sometimes you can put like a temporary crown there, like to just for looks. But I tend not to do that because if there's any force on that area, the implant is not going to set, and it's just going to fail, and you'll have to redo it again. So that's why I made an Essex retainer, so she can just wear it and have like a fake tooth there that is not touching the tooth below it and not disrupting the healing process. So in 4 to 6 months, the patient would come back, unscrew that cap, put a rod in there, and take an impression with the mold, send it to the lab, and then they'll bring me back a crown that can screw in there, and the patient will be ready to go. So the second case here, this was interesting. The chief complaint is my upper teeth are broken down and I want dentures. Again, no significant medical history. The treatment plan I proposed here were extractions, PRF, upper arch denture, and a lower arch removable partial denture. So again, we'll break it down. Extractions, just remove the bad teeth. PRF, it stands for platelet-rich fibrin, and I'll show you what that looks like in a second. Um, Upper arch denture is just, the upper arch is the upper, and then you have the denture, which is the false teeth. And then lower arch removable partial denture is the patient still has a couple teeth in the lower that we can use as an anchor. And we make a denture that can clip on, like hook around those existing teeth. So it's nice to have that on the lower because if you don't have any teeth to hook on, that denture just flops around because the tongue is always pushing there. So it's just better to have some stability. So here, this is the patient. After I did the extraction, I placed a butterfly needle to draw some blood. And then we put the blood in some tubes to put in the centrifuge and spin it. So after we take it out, this is what it looks like. It's like a jelly looking thing. This is the PRF, the platelet-rich fibrin. And it's basically filled with growth hormones. So we place that in the extraction sites to help out with faster healing. And, patients are pretty compliant about, or pretty okay with this because it comes from their own body. So I put the PRF in there and then I suture it up. And then the bone, we were waiting about 3 to 4 months for the bone to shrink to where it's gonna be more stable, and then take impressions to make her dentures. So the last case I have here is I had my implant placed 2 years ago and I still don't have a tooth. So this implant was placed in perio residency 2 years ago. So perio is short for periodontist. They specialize in, gum and bone. They do a lot of implants. So the residents in at UCSF, they placed this, and there were some issues with it where the implant was placed too palatally, meaning more towards the palate, angled backwards a bit. So it was difficult to have an aesthetic outcome. Another thing is this, he had a huge gap. Like this is a big space to fill in. And he actually has a natural gap between his two front teeth and another gap between the two teeth to the left. So this is my first time meeting the patient and he was already upset. So the reason why I share this is a lot of times on social media, you really only see people's best work. No one really likes to share their mistakes. But for me, I think it's important to really use it as a learning opportunity. The patient was upset, but I didn't take it personally because, I was just picking up the pieces and I just explained to him that I'm there to help him out. So, over a couple of visits, he realized that I was just doing everything I can to help him out, and he was happy in the end. But I'll walk you through what happened. So here's a picture on the left. That's the implant. That's after removing the cover screw, so you can see the actual implant there, and it's more. It's kind of hard to tell from this picture, but it's more towards the palate. Not the most ideal. So I took an impression and got the crown back from the lab, which is shown on the right side. But the big problem here is I was able to get floss between the gums and the tooth. So that's not good because, the food he eats will get trapped there and it can cause some irritation around the gums, or it could even cause the implant to fail. So here's another photo where it was just completely off. I was just really shocked, like, how did this happen? This is actually the second time I brought him in. The first time I brought him in, I got the gap in the middle right, but I didn't realize he wanted the gap on the other side of the tooth as well to match the other side. So yeah, this is after a second attempt already. So at this point, he's just kind of losing hope. He's like, I just want this front tooth already. And like, all right, let me figure this out. So what I did was I used the material, like the composite, which is the filling material we use for filling in cavities, and I added it on to this area that had the gap, and I shaped it to make it more flush with his gums. So here on the left, you can see it's closed, and this is the view from inside. And after verifying that the patient was okay with this, I sent it back to the lab so they can replace that filling material with a stronger material to remake the crown. Um, so eventually, it came back from the lab, and we got the space in the middle that he wanted, and the space to the other side of the tooth. He was happy with it, and I told him, in the future we can work on the other middle tooth to make it a little bit larger or add on some filling material to close up that gap a little bit, since that tooth is a little smaller than the crown that we did. Overall, he was really happy, and um, yeah, he was just he knew it was worth the wait, since I was doing everything I could for him. But that's it for me. I wanted to just save some time to answer any questions. If you have any comments or anything, I'm an open book, so really ask me any question. I'll do my best to answer those.
Okay, great. Thank you so much, Dr. Deleon, for taking the time to talk to us about your profession. It's truly appreciated, and I know I learned a lot from your presentation. To our viewers, just remember that we have a quiz that will stay up for 24 hours. So we do have a few questions on the Google Live chat. The first one is, was it hard to finish dental school while in a long distance relationship?
Definitely was. Yeah, it was really hard because we were basically long distance longer than we were together in person. Um, but what helped out was having a good group of friends to support me during that time, and um, just constant communication with my girlfriend at the time, right? So just definitely is a high level of trust being away for that long and being with people that they've never met. So just have open communication.
Okay, perfect. The next question is, in case one, when you're placing an implant, do you prefer one step or two-step implant procedure?
It depends. I'm not sure. Okay, let me go back. So if we're talking about the same thing, like first stage and second stage surgery, let me go back to this patient. This would be a two-step. So with the cover screw here, I would suture it up, wait a couple months, and at that point the gums would cover it, and then you'd have to use like a tissue punch to make a hole there and reveal the cover screw again. Um, in that case, in the front, I would definitely prefer two stage, because if not, you'd have the healing abutment sticking out, and it would be hard to put the Essex retainer over it. So in the front, two stage. In the back, I'm fine with one stage, since the healing abutment is hidden in the back. If you don't know what a healing abutment is, it's basically like a rod that sticks out of the implant instead of the cover screw that pushes the gums away. That way, when you do the implant impression, the gums are already conditioned kind of to have the shape of the root of the implant crown. So you have a nice emergence profile. So yeah, sorry to make that complicated. Front, two stage, back, one stage.
Okay, that's perfect. The next question is, what would a wrong angulation with an implant cause?
Wrong angulation. Oh, well, it would cause a lot of problems, like you saw with the last case I showed you. Um, Another thing that would be a disadvantage is, so with the crown, I've only done screw retained implant crowns where you could see the hole in the back of the crown. You screw it in and you cover it with a filling material. And if something goes wrong, it's easy to unscrew it and take it out. But if you had an implant placed too angulated, you won't be able to do a screw because you can't screw at an angle. So you'll most likely have to use a cement retained implant crown where you cement it on. And if something goes wrong, you probably have to just drill it off, which is unfortunate. Another thing is you could have a custom abutment, which is basically um, inside of the crown here. They can angle it so maybe you can maybe get away with a little angulation, but it costs more for the patient to have a custom abutment made because the lab charges more for that. So yeah, hopefully that answers your question.
Thank you.
Mhm.
The next question is, has anyone ever refused bone graft due to what it's made out of?
Yeah, good.
Are there
Yeah,
any alternate options?
that's a good question. Definitely, that's why in our medical history we always ask if there's any um, religious or personal or cultural beliefs that that would affect the dental treatment. So yeah, they would ask what the bone graft is made of, and they say cow, and their concerns are, oh, what's the side effects? And I joke with them like they're gonna say moo after or something, but jokes aside, there's there's not really an alternative. There's synthetic bone graft, but it's not really strong enough to hold an implant. So yeah, I mean at that point you'd be you could try doing PRF to allow for better healing and hope that the bone doesn't resorb as much. And then you'll just have to see in 4 months if that patient has enough bone for an implant.
Okay, thank you so much for that. Another
Mhm.
viewer has also asked, in case three,
Mhm.
would it be possible to take the implant out and put a new one in?
Yeah, yeah. So that's the beauty of screw retained implants. I could easily uncover the hole where the screw is, um, unscrew it, and then put a new crown in. It's really pretty straightforward to do.
Okay. Viewer has also asked, do you have any advice for studying for the DAT?
To be honest, it's been so long since I've taken DIT, so I don't know. I just remember I took a Kaplan course, and then kept redoing the question bank that they had. Like I would just repeat, 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 and then for the organic chemistry part, I think that was OChem or biochem. I would just draw them out on the whiteboard and understand or try to memorize that. That's all I have for that.
Okay, that's perfect. So another question is, how long does it take for you to feel comfortable working alone as a dentist?
Mm-hmm. Well, you know, it's really different for everybody. Um, I, s- I would say I didn't really feel that ready until 4 months ago. So in dental school, you get a lot of babysitting. They walk you through every step for the most part. Fourth year, you're more on your own, but they still have to like kind of check. And then in residency, what I liked was, they treat you as if, I mean, you're basically you are a dentist at that point. You're considered a doctor in residency, so they treat you like that. They just put you in, and um, they help you out only if you really need it. So they want you to struggle a little bit. And so I struggled a lot coming from dental school into residency. And then maybe 4 months ago, I'm like, I'm graduating from this soon. I need to just make my own decisions and trust myself. So I would say, like 8 months out of dental school is when I felt more confident.
Okay. Yeah. So the previous question I asked about case three and if it was possible to take the implant and put a new one. So our viewer corrected their question. They meant if it would be possible to take the screw and put a new one in with the correct angulation.
Yeah, you could do that. Um, yeah, it's really hard to take out an implant though. You do a lot of damage to the bone, and then you'd have to put a bone graft in after you take out the implant, pack it up, wait another 4 to 6 months for the bone to integrate, and then go back and do an implant. So it's really best to catch the mistake when you're placing the implant because you could still change the angulation a bit there. A way that this could have been avoided is doing a surgical guided implant placement. And what that means is we send the patient to get a 3D scan, a CBCT scan. They send us the file back to our computer, and we can program the angulation that we want to place the implant in, like to the exact degree and where it's going to be, um, and how the crown will look like. Then the lab, they print out like a surgical guide, which is basically a mouthpiece where with the hole in the with the angulation that you set on the computer. So on the day of surgery, you just go put the drills in sequence in that hole, and it's already going to tell you, it's going to guide you to the exact angulation and the exact depth. So it's kind of pretty straightforward from there. It takes like 20 minutes to do it, and that's it. Yeah, costs more, but it's safer.
Okay. Another viewer has also asked a similar question. In case three, when you're placing the implant, how do you decide the angulation? Is it a prosthesis guided implant or something else?
Yeah, definitely you want to have the prosthesis in mind of where you're gonna have it. That way you don't over angulate it. Um, but also you have to make sure that you avoid any nerves. So this really applies more so on the lower because of the IA, the inferior alveolar nerve. Um, that's why it's super important to get CBCT instead of doing it free-handed, because if you go in there and you hit the nerve, you can um, do a lot of damage.
Okay. And to piggyback off that earlier question, what's the difference between a surgically guided and a prosthesis guided implant?
Well, there's not really a thing as prosthetics guided implant per se. It's just you just have to keep in mind of where you want the crown to be. But the difference between surgical and non-surgical guided is basically freehanding it, putting it in, or having a mouthpiece. Like the first case I did um, non-guided. The reason why I was able to do this here is because the root of the tooth was there still. So when I extracted it, I just followed the direction of where the root used to be. I just had to go in a couple more millimeters deeper than the root of the tooth to get stability of the implant. So I guess follow the hole basically.
Okay. Another question is, I'm worried about not having good manual dexterity. How do you suggest I improve this?
Well, do some activities, even outside of dentistry, that you can practice hand dexterity. Like for me, I play a lot of music, play guitar, piano, um, a lot of instruments. So do something fun that you can practice hand movement. But also, like when you get into dental school, um, just spend more time in the sim lab, just practicing. You're gonna have the plastic teeth to work on. Um, some people are gonna be way better than you, but in the end, you all kind of just balance out, and it's just practice. Just don't feel um, bad if you're not good right away. Just keep practicing.
Okay. Um, what is something you struggled with in dental school?
Yeah, hand skills. So even though I did play a lot of guitar and all that, you know, it was still a little difficult to be able to drill on really tiny areas. So when you do like class two fillings on these plastic teeth, what that means is you have to drill between two teeth, and you have to make sure you don't hit the tooth behind it. So it's hard for me to be able to see with the mirror upside down and be able to drill on a tiny spot without hitting the other tooth. So another way I practice, that's called indirect vision, being able to see upside down with a mirror and working that way, moving the opposite direction. So what helped me was I practiced cutting my own hair. So I would just use mirrors and like be able to move in different directions, no matter if I'm looking straight on or through a mirror, to help my brain just practice that.
Okay. Um, how was housing while you were in dental school?
Housing, well, at LECOM, it's interesting because the first 3 years is in Bradenton, Florida, and the last year you move to either a more rural part of Florida or to Erie, Pennsylvania. So the first 3 years, the first year I moved in an apartment across from the school. That was just easy. And then just the next 2 years, I just found housing nearby. It's like a neighborhood. It's definitely nice to have roommates because of the cost. You want to save money where you can because you're already in a lot of debt, and it's good because you have like study partners. And then the last year when I moved to Erie, Pennsylvania, I just had to find like a house nearby too. So it's definitely mm, when you apply for a school, just ask where those students stayed at, and they'll tell you like the best places to be able to rent.
Okay, thank you. What was the lifestyle like as a dentist in the US?
Lifestyle, honestly, it was pretty laid back. It was a lot easier than undergrad. Um, so I mean, some parts were hard, but it was a lot more lax than I thought it would be. Definitely still have to study hard for the test. A lot of times I would be, relaxing at the beach or at the pool and just hanging out with friends. Like we would have a lot of um, cooking parties where we just have people come over, play some games, eat some food, and then just studied maybe like 3 hours a day at most, mostly just on the weekends, honestly. So it wasn't too bad.
Okay, so we're just gonna finish up with this last question. What is your favorite procedure to do?
My favorite procedure, I like doing extractions. I know it can get kind of bloody, but it's just something gratifying when you take out a tooth that's really stubborn to get out. Um, and then the patient, there, it's nice for them because they'll be out of pain after. Um, I don't know. I guess I like extractions and surgery.
Okay, so I just want to thank you once again for taking the time to talk to us today, and to everyone else, have a great day.
All right. Thanks, everybody. Have a good night.